For those of you who know me, I think, as you also heard from Dr. Devaskar, I'm wearing two hats these days. Of course, my interest in pediatric GI really stemmed from my love for our liver transplant patients, and I've developed immune monitoring interest in transplantation. And that actually bridged to me now developing an immune monitoring interest in other pediatric GI disorders, namely EoE. So I'll be speaking with you today about EoE, which is an emerging disease. I'll be covering all 6 of the ACGME competencies during the course of the hour. And the general outline that I've put together for this talk is first to answer the question, what is EoE? As I've mentioned, this is an emerging disease, and I would say probably maybe half of the people in this room didn't even learn about it during their training. So we'll go through the definition and the pathophysiology, and then we'll focus on the clinical presentation in terms of epidemiology and symptoms, and we'll focus the last half of the hour on diagnosis, treatment, and future directions. As far as the objectives for you all in the audience, I hope at the end of the hour that you'll be able to better recognize the clinical symptoms of EoE, know when you should refer patients to be seen by pediatric gastroenterologists for EoE workup, and then also understand how we diagnose and treat EoE. So before I get to the meat of the talk, and the pun was fully intended there, I want to share with you this story that I've titled The Pork Paradigm. And I want you to think about this patient and how you would manage him. This is a 14-year-old previously healthy boy who comes into the emergency room with a chief complaint of a bite of pork stuck in his proximal esophagus, right here in his throat. And he says that it happened a couple hours ago while he was eating dinner, and he's had numerous glasses of water to drink to try to pass this piece of pork, and it just won't go down, and he's very uncomfortable. When you examine him, you see that he can swallow his own saliva, and he has no respiratory compromise. But he's just very uncomfortable. And so in the ER, he's instructed to drink some soda to see if that will help the pork pass. And after 2 sips of Coke, the pork passes. The young man feels great. He's happy, smiling, ready to go home. You're a little bit worried about sending him out, but you ask him, has this ever happened before? Have you ever had problems swallowing before? And he says, no, this is a one-time event. Nothing like this has ever happened before. So what I want you to think about is, what instructions would you give this young man as he's leaving the emergency room? And maybe by a show of hands, I'd like to see, this is a one-time event, never happened before, the kid feels great now. How many of you would choose option A, give him anticipatory guidance, make sure he doesn't eat so quickly, make sure he thoroughly chews and swallows his food? So by show of hands. So maybe 3/4 of the room. Okay, and that makes a lot of sense. How many of you would suggest, well, maybe you should go see your PMD, maybe there's some kind of anatomic problem in your esophagus, some kind of narrowing. PMD should order an esophagram, so follow up with the PMD. No one? Oh, couple hands maybe. And then how many people would refer to pediatric gastroenterology? All right, all the gastroenterologists and the allergy immunologists in the room. Excellent. Okay, that's perfect. That's the answers I was hoping for. So keep this young man in mind, and we'll return to him at the end of the hour. So what is EoE? EoE is a chronic immune-mediated esophageal disease, and it manifests itself by patients having symptoms which are related to esophageal dysfunction and eosinophil predominant inflammation on mucosal biopsies. And it's interesting because when you actually look at the data, even though EoE is not all that well recognized across the board of medical providers, when you look at the GI data, it's actually one of the most common conditions diagnosed during the assessment of feeding problems in children and during the evaluation of dysphagia and food impaction symptoms in adults. I mentioned at the start of the talk that a number of you probably didn't even learn about EoE during your training, and that's because it's a relatively newly described disease. The histologic and phenotypic features were first described in 1993, and it was reported to be a unique disease entity in 1995. Originally, EoE was thought to be quite rare, and we've now seen that the prevalence of EoE is greatly increased, and part of that is because there's been an increase in the interest in EoE. Initially, it was reported in the Northeast United States and in parts of Europe, specifically in Switzerland. And as you'll see in some of the later slides, it's now definitely spread to a much larger geographical landscape. And so the question that's been posed is EoE a new diagnosis, or is it simply a recently recognized disease? And the answer to that actually remains unclear, despite all the research that's going on in the world of EoE. So I have a couple slides on pathophysiology before we get into the clinical side of things. EoE is driven by intraluminal allergen exposure within the esophagus, and we know that both environmental and food antigens are implicated, but it does seem to be that food antigens are really the primary culprit. We've learned that this is, while oftentimes linked to patients with IgE-mediated food allergies, EoE itself is a non-IgE-mediated process, and it is mediated by Th2 cell activity, and it's known that IL-13 is quite important in inducing an inflammatory response in the tissue. And you can see with the diagram that it starts as a process of enhanced antigen presentation in the esophagus. That leads to recruitment of eosinophils with subsequent release of inflammatory mediators and the resultant clinical effects we see of esophageal dysfunction. So if you take a closer look at pathophysiology, the underlying link is that the disease leads to an impaired barrier function in the esophagus. So I mentioned that IL-13 is responsible for inducing inflammatory response in the tissue and leading to modification of esophageal transcripts, including eotaxin 3, which then is a chemoattractant and draws eosinophils into the esophageal mucosa. You end up seeing downregulation in a number of barrier function proteins and adhesion molecules in the esophageal mucosa, including DSG1 or desmoglein-1, as shown here. And you end up having dilation of the interepithelial spaces, as shown here. We'll see some actual histology biopsies later in the talk. And the esophagus mucosa then has altered permeability, which promotes then tissue remodeling deeper in the mucosa, and ultimately then propagates the allergic inflammatory and cytokine response in the esophagus. So it kind of is a self-propagating event then, in that you have increased inflammation that continues to be revved up and eventually can lead to fibrostenotic disease in the esophagus. So how does EoE clinically present? And here's where I think we'll hear a lot of interesting facts here. The prevalence of EoE is estimated to be about 0.4% in Western countries. So that's the US as well, actually, as Australia. So that's not all that uncommon. That's about 1 out of 250 patients will have EoE. It is, however, increasing in prevalence really across all areas, especially in Asia and the Middle East. It's been described in all age groups, so young children, even infants, as well as adults and elderly patients, and it's also been described across all races and ethnicities. But we do know that it predominantly affects white males, and the male predominance is about 3-to-1. And when you look at the prevalence data from the US, as you can see here, the males are shown in the black bars and the females in the white bars. You again see that there is a male predominance. And you see that there's kind of a bimodal distribution in terms of diagnosis and disease symptoms, where a number of patients are diagnosed kind of in the school-age childhood years, and then a number of patients in the young adult age years. Most patients are diagnosed before age 50. So you might ask, what are the genetic factors that predispose patients to developing EoE? And this paper here, as well as a number of the papers I'll cite in this talk, were published by the Rothenberg group out of Cincinnati. And Dr. Rothenberg has really been a leader in advancing the EoE research. And his group performed some genome-wide association studies. And the one shown here was one of his earlier studies, where he looked at 350 patients with EoE and compared them to just over 3,000 normal, healthy control patients. And as you can see, he identified 2 genes of interest, this TSLP and this WDR36 gene, which looked to be associated with EoE. But they then went down to look at the tissue level and determined whether or not these gene transcripts were then overexpressed in esophageal mucosa. And with this first gene, this WDR36, there was no difference in esophageal expression between normal and EoE patients. But when you look at this TSLP gene, there was a differential expression with higher levels expressed in patients with EoE. And when they looked at the function of this gene, it turns out that TSLP is a cytokine that's produced by keratinocytes, and it also promotes the development of Th2 cells. So there definitely is some biological plausibility here. And this TSLP has also been associated with other atopic diseases. So there's definitely genetic factors playing a role. This group then went on to confirm their data looking at a larger cohort of patients with additional genome-wide association studies. In this data here, they looked at over 700 patients with EoE and compared them to close to 10,000 healthy controls. And you can see this time around, they identified a greater number of genes of interest on a number of different chromosomes. But the one that was of most interest was this gene here on chromosome 2, this CAPN14 gene, which, again, when they looked at esophageal tissue, it was found to be upregulated with disease activity in biopsies from patients with EoE. This gene is responsible for encoding calcium-dependent proteases, and the substrates for these proteases, of course, would include adhesion molecules, which we've already talked about are affected in patients with EoE. And this gene is also modified by IL-13. So again, definitely there's some biologic plausibility in terms of why this gene may increase your susceptibility to EoE. The group has since gone on to identify a number of other genes that I've just listed here, not to go through all of these in detail, but for you to appreciate that with gene studies, we are identifying a number of genes that would increase someone's susceptibility to EoE. But if we look at that on a more clinical level, looking at family studies, I found this recent publication to be quite interesting. This study, as you can see, finds that there is a higher concordance rate of EoE in monozygotic twins compared to dizygotic twins. But it's only 41% of monozygotic twins, 22% of dizygotic twins. What's most interesting is that this is tenfold higher, this 22% is tenfold higher than what's reported as far as concordance in siblings, 2.4%. So this implies that there's some kind of early life exposure that may increase someone's susceptibility to EoE. And if you look at overall heritability, you have about a 2% risk of developing EoE if you have a relative with it. So what might some of these early life exposures be? And there's been a number of studies that have looked at this, and we see that there's a number of kind of neonatal exposures that are important. So if you were exposed to antibiotics in infancy, you have a 6-fold higher chance of developing EoE. If you were born by C-section or if you were born early, you have an increased risk for EoE. If you had exposure to group B strep, exposure to formula, and maternal smoking, that also increased your risk for EoE. So there definitely seems to be some kind of altered stimulation of the immune system early on in life that may confer a predisposition to developing EoE down the line. One of the hypotheses that's been thrown out is that perhaps this is all related to changes in the esophageal microbiome. And microbiome is, of course, this hot topic in the world of GI and a lot of other organ systems as well. But perhaps there's some changes in the eosinophilic microbiome that leads to some kind of dysbiosis, and you end up having an increase in antigen presentation or recognition in the esophagus. A number of other environmental factors have also been implicated. Seasonality seems to play a role. More cases of EoE are diagnosed in spring and summer months. Climate seems to be important, with more cases in cold and arid climates, especially in the northeastern US. Location. It's more common in rural areas. And I mentioned geography. There's very few cases of EoE that have been reported in tropical areas and developing countries. And in fact, if you look at the literature, at least as of a year ago, there may be some publications coming out now, but there really have been no cases reported in India and in sub-Saharan Africa. But as you remember, patients of all race and ethnicity can develop EoE. It just depends on the environment that they're living in. So here's where we jump into the fun. How do these patients clinically present? I think it's important to realize that EoE can be diagnosed at any age, and it's actually still unclear as to whether or not patients who are diagnosed later in life had unrecognized or potentially subclinical disease symptoms, or if they actually had a late onset development of EoE. It would seem that maybe the first is true, and we'll get more into this as we get further in the talk and talk about the development of fibrostenotic disease. But you can see that young patients present with different symptoms than older patients. infants will often have very nonspecific symptoms when they present. They may just have some general feeding difficulties and failure to thrive. And that's different than what we see in school-age kids who complain of nausea, vomiting, pain, potentially heartburn type symptoms. And that's different from what we see in adults. Adults tend to present with solid food dysphagia or food impaction. And when you look at the data, it's actually that 50% of adult patients who are scoped for food impaction go on to be diagnosed with EoE. So that's 50% of patients with food impactions. When you talk with these patients and kind of elicit a history, you can actually learn that a lot of these patients have developed ways of accommodating with their symptoms over many years. So patients with EoE oftentimes will tend to report that they eat slower than other family members. They tend to chew their food carefully. They like to cut their food into small pieces. They lubricate their food using a lot of ketchup or barbecue sauce. They tend to drink a lot of liquids while they're eating to help the food pass down the esophagus. And they also tend to avoid pills and meats and breads. It's especially the meats and dry bread that tend to get stuck in the esophagus of these individuals. It's also important to know that patients with EoE very often have personal or family history of atopic disorders, including eczema, IgE-mediated food allergies, asthma, and allergic rhinitis. And you can see that if you compare children with EoE to children in the general pediatric population, the kids with EoE are about 2 to 3 times more likely to have either a personal or family history of allergy, asthma, and allergic rhinitis. So as I've gone through this clinical presentation, I'm hoping, if I've done my job right, that I've scared you guys into thinking that perhaps you're missing a lot of these patients without realizing it, and perhaps you should be referring more patients to be seen by pediatric GI providers. And maybe a few of you in the audience are even thinking, oh my goodness, food gets stuck when I swallow, maybe I need to get an adult GI referral. So that was my intention, but I also need to remind you that as much as I'm saying this is a common disease, it's still only about 1 out of 250 people have EoE. So how do we diagnose EoE? I mentioned that these patients need to have symptoms of esophageal dysfunction, and this has to be linked to the presence of esophageal eosinophilia. And that's defined as at least 15 eosinophils per high-powered field on esophageal biopsies. Now, historically, it used to be thought that esophageal eosinophilia was really just a manifestation of GERD, a gastroesophageal reflux disease. But we've since learned that eosinophilia can be seen with a number of different disorders, along with EoE, the number of disorders that I've listed here, including things like celiac disease, connective tissue disorders, other autoimmune diseases, in particular Crohn's disease and vasculitis, as well as graft versus host disease. And it can also be seen in the case of infections. So that's important to keep in mind. So the American College of Gastroenterology has given us a very clear diagnostic algorithm that we follow in order to diagnose patients with EoE. And as you can see here, when patients are scoped, they have to have documented eosinophilia on their biopsies, and we need to look for other causes of eosinophilia. We also need to confirm that the eosinophilia is isolated to the esophagus, that it doesn't involve all of the GI tract, because that would then put them in a different category. And patients then have to undergo a PPI trial. So patients are treated with 6 to 8 weeks of PPI therapy and rescoped. And the reason why this has to happen is because we know that about 50% of patients will have what's termed PPI-responsive esophageal eosinophilia. And these patients potentially have an element of GERD that's contributing, but they may also just have this separate disease entity of this PPI-REE. If the eosinophilia persists, they then fall down this pathway and end up earning themselves a diagnosis of EoE. So just to make sure that's clear in everyone's mind, these patients have to have symptoms related to esophageal dysfunction, an eosinophil predominant inflammatory infiltrate in their esophageal biopsies. This needs to be isolated to the esophagus, secondary causes need to be excluded, and it needs to persist after a PPI trial. And once you meet those 5 criteria, you have EoE. So what do we see on endoscopy? These endoscopies can look very different in different patients. And to put things in context, I first want to show you a picture of a normal esophagus on endoscopy. You can see that it's nice and smooth and pink. You can see a normal vascular pattern. And this is what we like to see when we scope patients. What we don't like to see is something like this. These are a couple pictures from 2 of my patients with EoE. You can see here that these patients have white specks in the esophageal mucosa. They have mucosal edema, which is seen in these linear furrows that really are not there in patients with normal esophageal mucosa. This patient here is a 6-year-old female who was referred to me for very refractory GERD symptoms. She was constantly refluxing and regurgitating all day long despite being on BID PPI therapy. And she did have confirmed eosinophilic esophagitis. Her case looks a little bit more mild compared to the patient here on the right. This was a 15-year-old young lady who presented with dysphagia and food impaction, and she also was confirmed to have EoE. From the literature, I have a couple pictures here of another finding. These are termed esophageal rings. They're concentric rings that you see throughout the esophagus. It's sometimes also called trachealization or felinization because of the way it looks. Some patients, as I've mentioned, will develop fibrostenotic disease and develop strictures. And here you can see this part of the esophagus is more narrow, and here you can see kind of an area that looks tight. We as endoscopists can actually sense this as we're passing the endoscope through the esophagus. It's sometimes tight. And then when we take our biopsies, we feel something that's referred to as the tug sign, when it just feels harder as you're removing the biopsy from the patient. There's something that's called Crepe-Paper Esophagus that's been reported. This is when the esophagus is so friable that just with simple passage of the endoscope, you develop a linear tear in the mucosa. Patients can also have fragility and bleeding on endoscopy. These photos were taken from a 13-year-old boy who had actually had a couple years history of some very mild abdominal pain that was thought to be functional abdominal pain. And then he actually presented to the ER with hematemesis. This is not a common presentation for EoE, but it has been reported. And here you can see he does have these linear furrows. He has gross findings of esophagitis with this very friable mucosa with some white ulcerations. And you can see that he was bleeding from his distal esophagus. Dr. Guerra, Marjorie Guerra, is one of our first-year fellows, published this case report with myself and with Dr. Vahabnazad last year. This is a young woman who had EoE with something that's quite rare called Esophagitis Dissecans. And she actually had a scope performed as a follow-up for a history of a perforated gastric ulcer, which in and of itself was interesting, and had some very mild esophageal symptoms. And when we scoped her, you can see that her esophagus looked terrible. Essentially, the entire lining of the mucosa had sloughed off. It was almost as if it was kind of a skeleton of the esophagus had come off, and like as if a snake was shedding his skin. And remarkably, her esophageal symptoms were not all that impressive. And this was an interesting finding to us. This esophagitis dissecans is something that's rarely reported, usually in elderly patients with bullous diseases or potentially elderly patients on medications, particularly SSRIs. And this young woman responded quite well to therapy, and on repeat scope, she did have resolution of this very abnormal mucosa. So my favorite, food impaction. These pictures are not pleasant to look at, and these patients feel terrible. If the food impaction is proximal, oftentimes they feel like they're choking. They feel like they can't breathe. Even though their airway is intact, it's very, very uncomfortable. And probably you're looking at these pictures thinking, my goodness, thank goodness I don't have Laura's job. And that's maybe true, but you can see here, look at this mucosa. It's terrible. This poor patient has a whole bunch of this white exudate. A lot of this is probably eosinophils, and then this semi-chewed bite of meat. This patient, I think, is quite interesting. This is actually not the patient I presented at the beginning. This is another 14-year-old boy, and he was unique in that he had a long-standing history of food allergies. He'd actually been followed by an A&I doctor since before the age of 2. And he actually had come into our ER for a penny in his esophagus at 3 years of age and had been scoped at that time but had not undergone biopsies. And then 10 years later, he came back to the ER with food impaction and required another scope. So we've now confirmed a diagnosis of EoE in him. I also think this picture is important to look at because you can see that this is not that big of a food bolus here, and it makes you wonder, why doesn't it pass in patients with EoE? Most of us in this room, if this were a bite that we swallowed, we'd drink a little bit of water and it would go down. But the analogy that I use is that the inside of the esophagus almost looks like flypaper or sticky tape, and as food tries to pass down, it gets stuck along the way. As soon as it gets stuck, it triggers an increased inflammatory response, and so then it's kind of like, there's no way it's going to come out until we remove it. So I've shown you the range of features we can see on endoscopy, but what do the biopsies look like in these patients? So in terms of biopsies, there are some good recommendations from pediatric GI societies that we need to perform at least 2 to 4 biopsies from 2 different locations in the esophagus. At a minimum, you need to biopsy the proximal and the distal esophagus. And that's because you need to see eosinophilia throughout the esophagus. If you just have eosinophilia isolated in the distal esophagus, that suggests a diagnosis of reflux. But if you have eosinophilia throughout the esophagus, that goes along with EoE. I typically like to obtain biopsies in the mid-esophagus as well, and part of this is because it helps you gauge where is the esophagitis the most pronounced, where is the eosinophilia the most pronounced, and sometimes patients that have a larger contribution of symptoms from aeroallergens will have more eosinophilia in the proximal esophagus compared to the lower esophagus. There are clear recommendations that children should also have biopsies collected in the antrum and duodenum. The evidence is a little bit less clear in adults, so typically adult providers will biopsy only if they see gross abnormalities in the stomach or the small bowel. But in kids, we do take biopsies even if things look normal. And though there's not a clear recommendation that you have to take biopsies in patients that have esophageal foreign bodies, there is now mounting evidence that you should take biopsies in patients with food impactions. And based on the patients that we've seen here at UCLA, my practice has become to take biopsies even if a child comes in with a coin that's stuck in the esophagus, because it makes you wonder, why did that child have the coin get stuck when the majority of children will just have that coin pass? As far as how many biopsies to take, there is an increase in diagnostic yield with a greater number of biopsies. So you can see if you only take a couple of biopsies, there's maybe a 20% chance that you might miss EoE. Whereas if you take 6 biopsies in the esophagus, you're essentially 100% likely to make the diagnosis. So that's what our standard of care is. The same group that developed this algorithm for a number of biopsies published in their paper the reason why you need to have multiple biopsies. And this is a set of biopsies from the same location in the same patient, and you can see that the biopsies are very different. The first biopsy is completely normal of the esophagus, and the second biopsy shows findings of EoE. So here you see a nice, smooth squamous epithelium. In the patient with EoE, it's somewhat disrupted. And you can see that there's an inflammatory infiltrate. Eosinophils are spotted in here, and there's an eosinophilic microabscess. Here's a couple more images of what we see in biopsies of patients with EoE. Again, you see the sloughing of the apical epithelial cells, and you see hyperplasia of the basal cell layer. You can also appreciate some spongiosis here. There's increased space in between these epithelial cells, reflective of the leaky mucosal barrier. And on deeper biopsies, you can see that there's fibrosis that develops in the lamina propria. And these are the patients that unfortunately go on to develop fibrostenotic disease. So we've gone over the clinical presentation and the diagnosis of EoE. How do we actually treat it? Fortunately, we have a number of treatment options for these patients. And for me, the option that I choose will oftentimes depend on the patient and the family's preferences. So we'll talk about the pharmacologic therapies and the dietary therapies that are available. Briefly, I just want to review again the importance of a PPI trial. As I showed you in the algorithm earlier, the first-line therapy for patients with esophageal eosinophilia is in a 6 to 8 week trial of PPI therapy followed by repeat endoscopy. And I mentioned that about half of patients will have improvement of the eosinophilia on the PPI therapy alone. And so those patients are deemed to have PPI-responsive esophageal eosinophilia, different than EoE. And in those cases, ambulatory pH monitoring is often helpful to determine how much reflux may be contributing to their symptoms. But for the patients who go on to have a confirmed diagnosis of EoE, option number 1 is treating them with topical steroids. And topical steroids have been proven to be effective in randomized trials in both children and adults. And the way you use topical steroids is by instructing the patient to swallow the steroid, rinse their mouth afterwards so they don't develop oral thrush, and then they should avoid eating or drinking for about an hour so that the medication has time to stick in the esophagus and locally act. The response rate in the literature is about 60%. I'd say for me, clinically, it tends to be a little bit higher than that. And generally, it's safe. Fewer than 5% of patients may develop some kind of candidiasis infection. So what are the two options in terms of steroids that have been studied? Your first choice would be fluticasone, which is familiar to a lot of families, especially because a number of these kids have either a personal or family history of asthma. And patients will take 1 or 2 puffs of different varying strength inhaler depending on their age, and probably do that twice a day for most patients. The alternative is using budesonide, and the studies have shown that you can use nebulized budesonide that's then swallowed, but what works better is this concept up here that's called an aqueous viscous solution. And I don't love this choice. You have to take the respule of budesonide and mix it with 5 grams of sucralose. And I've shown the picture here. It's like 5 packets of Splenda. Most parents kind of don't really like this idea. I also think in terms of compliance, so many families are familiar with inhalers. If you have older kids who are going to be going to sleepover parties or camp, it's very easy to bring an inhaler along. It improves compliance as opposed to having to mix this slurry a couple times a day. So for most patients, I recommend the fluticasone option. Now, there's some families that say, oh my gosh, steroids, I don't want to use steroids in my child. I definitely would prefer a more natural approach to treating EoE, and I'd rather do a dietary therapy. And so there's been a number of studies that have looked at the food culprits in EoE, which actually appear to be different in children and adults. So the data shown here is from a pediatric study that looked at children retrospectively who had been followed very closely at Chicago at Children's Memorial, and had foods eliminated from their diet and reintroduced one by one, followed by repeat endoscopies after each food reintroduction, so that they could determine which foods were the culprit in causing disease recurrence. And as you can see here, milk is most often the culprit. 74% of children had eosinophilia return with reintroduction of milk into their diets. You can see the other common players were wheat, egg, soy, nuts, and in this study, seafood was 0%, although that has been shown to be involved in other studies. And you can see these numbers don't add up to 100% because many patients, about a third of patients, will have multiple food allergens that are triggers for their disease. So with this in mind, we end up having 4 different choices for food dietary therapy in terms of elimination diets. The most stringent diet would be a completely elemental diet, which is successful at least 96% of the time, perhaps more often than that. But this is very costly and unpalatable. Patients have to essentially go on formula-only diets. And because these formulas don't taste very good, most of these patients require feeding tubes. The other options would be a 6-food elimination diet, a targeted diet, or a milk elimination only diet. And you can see I've listed there the 6 most common allergens in EoE: milk, soy, wheat, egg, nuts, and fish. And if you eliminate all 6 of those foods, you have about a 75% chance of having your EoE resolve. Targeted diets, interestingly, are not that far off from the 6-food elimination. So targeted diets would be guided by clinical history and allergy testing. So this is when I very much rely on my allergy immunology colleagues as well as dietitians, because really these targeted diets will require consultation with these providers, not only to determine which foods patients are sensitive to, but also to get nutritional counseling so that children don't develop any nutritional deficiencies as they're removing foods from their diet. And then the milk-only elimination diet has been documented to be about 65% effective. I'd say in my clinical practice, I'm not sure it works quite that well. The adherence is obviously easiest because children only have to eliminate milk products, but you have to keep in mind that it's all milk products. So it's not just that they have to stop drinking milk. This happens with adults all the time. They also have to stop drinking their lattes in the morning, and they can't have products that have cooked milk in it either. So again, the choice of which diet you're going to select depends on the child's age as well as the family preference. So once we decide on a treatment therapy, we like to treat patients for a good 6 to 8 weeks before we assess their response to therapy. And there's a question within the field as far as what our treatment goals should be. Should we treat patients just to having resolution of their symptoms? Should patients have gross endoscopic improvement, or should we treat to the point of normalization of microscopic abnormalities? And the third option is what I aim for. So you want to have histologic remission of your disease. It's also been put out there as to whether or not you should actually treat to the point of patients developing esophageal remodeling. And that's because studies have shown that even if you have normal esophageal biopsies, when you look at protein expression in the biopsies, it sometimes is still abnormal with upregulation of involved proteins. So that question still remains as far as what your endpoint should be. But most people would, at a minimum, lean towards gross endoscopic improvement, and again, like I said, for me, histologic remission. So why is it so important to have follow-up exam to make sure the esophagitis has improved? It's because longer-term studies have shown that patients with EoE do have increased risk of fibrostenosis in the esophagus. This study was performed in 200 patients who had symptomatic EoE, and they basically looked at the diagnostic delay in terms of the time that the patient first recalls symptoms starting until the time that the patient underwent endoscopy for their symptoms. And you can see that patients who presented or were scoped earlier, within less than 5 years, were more likely just to have a normal esophagus on gross exam or just inflammatory changes, about half of the patients. Whereas if patients waited 10, 15, or even 20 years before they underwent endoscopy, they were much more likely to have inflammatory and fibrotic lesions seen on endoscopy. Now, similarly, this group looked at close to 400 patients at all different ages and looked at whether or not these patients had fibrostenotic disease. And definitely from this figure, you can see that the risk of developing fibrostenosis increases with age. And if you look at the numbers, it's about a 5% increase in developing fibrostenosis for each year of symptoms. So it is important to catch these patients early in the disease course and to effectively treat them so that hopefully they won't go on to develop fibrostenotic disease in the esophagus. So that's why a follow-up endoscopy is helpful. So I mentioned we typically will repeat an endoscopy about 6 to 8 weeks after starting therapy. And what we hope to see is that the eosinophilia has resolved. If it's resolved, we'll consider weaning the steroid dose, typically down to a lower dose where a patient continues not to have symptoms. And if a patient is on a very strict food elimination diet, we may consider reintroducing food allergens. Now, in terms of food allergens, this could be a whole talk in and of itself, so I'm not going to go into the details, but this is where, again, I really rely on my allergy immunology colleagues and the dietitians, because there's a number of studies that have looked at which foods are most allergenic and least allergenic and which order you should reintroduce foods. And again, I mentioned the data is different in children and adults. So this is something that you have to be very thoughtful about in these patients so that you have increased likelihood of success at reintroducing foods into the diet. So what if the eosinophilia persists? Gosh, EoE is very difficult to say. So what if the eosinophilia persists? You want to assess adherence and potentially adapt treatment. So oftentimes it turns out that patients aren't using their swallowed steroids appropriately. Maybe they're eating right afterwards. Maybe they're using the wrong dose. If they are using it correctly, then you would want to consider switching them over to an elimination diet, and vice versa. If they're properly following a diet, then you might give them a trial of topical steroids. And additional endoscopies may then be performed if a patient responded to therapy, if they have symptom recurrence, and even in kids who are asymptomatic, it really depends on where they're at, but oftentimes we'll decide to do surveillance endoscopies here and there to make sure the disease is still in remission. So I've mentioned this problem of fibrostenotic disease, and I want to show some pictures to you of what this looks like and what we're able to do in terms of treating it endoscopically. This really is more often a problem in adult patients with EoE, but it has been seen in children as well. So you can see here this patient has these areas of tightness in the esophagus. And just with passage of the scope, you can see some bleeding. And what we're able to do is advance balloon dilators into the esophagus, inflate the balloons, and it provides circumferential pressure. And this is when the scope is right up against the balloon here in figure C, so that you can see that there's this stretch being placed circumferentially on the esophagus. And you know your dilation is successful when you see this tear in the mucosa, that you've been able to stretch the lumen up to a more appropriate diameter. And here's where I want to take a moment to let you know that there does seem to be an increasing role for esophagram in patients with EoE. So figures A and B show some areas of mucosal irregularity and some narrowing. And again, in C here, you can see an area of focal narrowing as well as in D. And so it is possible to pick up strictures on an esophagram. And this group from Colorado actually looked at whether or not you were likely to pick up more strictures on esophagram as opposed to looking at the esophagus on endoscopy. And they actually found that the esophagram was more sensitive for picking up strictures. And these sample photos are from a patient where you can see there's some narrowing in the esophagus that really isn't all that apparent on the endoscopy. And after dilation, you can see that this patient does have this linear tear, suggesting that the dilation was successful in the superficial mucosa. And when they looked at numbers in their study, they found that 55% of children with strictures were not diagnosed by endoscopy and in fact were picked up by an esophagram. So the esophagram may pick up subtler disease. And for me now, although I don't love to expose children to radiation, I have found for a number of patients that it's useful to start with an esophagram and assess for any narrowing. Okay, so I think I've gotten through treatment, and now we'll spend a few minutes on future directions. Most of the research in EoE is looking at two areas. First, in kind of the clinical arena, what are therapeutic alternatives for patients, especially patients with refractory disease? And what are the potential biomarkers that we can use to follow these patients so that we hopefully don't have to subject them to invasive endoscopy as much as we currently need to? So in terms of looking at refractory disease, when patients don't respond to the treatments that I've covered, really the best option we have is use of systemic steroids. And as we all know, it's not a good thing to keep children on steroids in the long term. So this is something that we can use to induce remission, but then we sometimes struggle to maintain remission in these patients. There's been a handful of studies that have looked at use of immunomodulators, 6-mercaptopurine and azathioprine. Most of these have looked at adults, and there's just not robust enough data to say whether or not these are helpful in children at this point. And so a number of kind of clinical researchers are looking at antibody therapies, which sound very enticing. Things that have been tested are anti-IL-5 therapies, IL-13, and also anti-IgE therapies. Unfortunately, none of the studies have really yielded robust clinical effects from these antibody therapies. And so there's still kind of this looking for other novel targets that's happening in the research arena. And targets that have been proposed are listed here. And it would be great, of course, if we could develop a medication that would potentially target these chemoattractants, this TSLP that I mentioned, the eotaxin, and potentially even eosinophils. But this is really something that's still kind of a pie in the sky. Where I think we're a little bit further along is development of markers looking at disease activity. And again, the Rothenberg group that I mentioned out of Cincinnati has done some really nice studies in this area, where they take patients with EoE, they take biopsies during their endoscopies, they extract RNA, amplify it with PCR, and then they perform these beautiful signature analysis studies and take into account clinical factors as well. And they found that patients have very different transcriptomes if they're normal patients compared to reflux patients, compared to patients with EoE or the PPI responsive eosinophilia. And what's nice is that you could theoretically save a patient a biopsy if you run this transcriptome with the initial endoscopy and then look to see, is this a patient that's going to respond to a PPI, or is this a patient that's going to have EoE? You could potentially just jump to the correct treatment and not have to go back in to rescope the patient. So this is still something that's in development, but does look to be relatively promising. The problem is this does still require biopsy, and so of course the best biomarker would be one that did not require endoscopy and biopsy. So this is a nice figure, again, by the Rothenberg group that really kind of pieces everything together in terms of what we know about the pathophysiology of EoE. And a number of groups have looked at potential serum markers. A lot of the markers are ones that are kind of named throughout here, looking at all sorts of different interleukins, eotaxin, other cytokines. The problem is none of those have panned out to be reproducible, and that patients will have potentially elevated serum levels, but they don't correlate with esophageal disease, or it may be increased in the esophageal tissue, but isn't found in the serum. So we're still looking for a good serum marker. And here's where I want to just direct your attention to the newly recognized role of IgG4 in EoE. This is something that's been studied by two groups. I've cited the Clayton and Zuckerberg paper. And this is also going to be the focus of one of our first-year fellows, Dr. Amanda Pope's research as she goes on the next couple of years. And she's just submitted an excellent T32 proposal in this area. The background here is that it looks like tissue IgG4 has increased expression, or it's picked up in higher volume in patients with EoE compared to control patients. And you can also see in the staining that there's this patchy red staining of intercellular IgG4 in the esophageal mucosa. And what's promising is that we're not just seeing this in the esophagus in the biopsies, but we're also seeing it in the serum. So the same study looked at levels of total IgG4 as well as food-specific IgG4 and found that there are statistically significant differences between patients with EoE compared to control patients. Now, the problem is that there's also a lot of overlap. So this definitely isn't the endpoint, but this is something that will be the basis for future studies, and hopefully Dr. Pope's study will further elucidate this. Okay, so in the last few minutes, we'll go back to the patient I presented at the beginning, the pork paradigm. So if you guys remember, this is a 14-year-old previously healthy young man who came in with pork that was stuck in his throat, and it passed after he swallowed a couple sips of Coke. And I want to now re-poll you guys. So now that you've heard this talk, you're giving him ER discharge instructions. How many of you would settle with just A as your answer? Just anticipatory guidance. Okay, a few people still would. How many people would consider ordering an esophagram in this patient? And how many of you would refer this patient to see one of us? Excellent, you guys have learned. I always make trick questions. The residents who've rotated with me know this. So I think actually the correct answer is probably all of the above. That's the approach that we took. So for this young man, I actually saw him with Dr. Pope, who elicited a very good history. And on further questioning, it actually turned out that he'd had problems swallowing throughout his whole life, or at least for the last few years. He'd never had a true food impaction, but certainly there were some foods that were a little bit more difficult for him to swallow. He was a slow eater compared to his family. So he'd actually learned to probably accommodate to some of the symptoms. So we did move forward with endoscopy. And these pictures are a little bit blurry. I apologize for that. It wasn't totally normal on the endoscopy. He did have some linear furrows, as you can see here, but it certainly was not as pronounced as some of the other images that I showed you earlier in the talk. So this patient did have confirmed eosinophilia on his biopsies, and he's currently undergoing his 8-week trial of PPI therapy, and we'll be rescoping him in March. And at that point, we'll know whether or not he has true EoE or if it's more of the PPI responsive EoE. I mentioned I did also get an esophagram on him, and that was normal. So he doesn't have any strictures that have developed. So let's summarize what we've learned. EoE is either a new or recently recognized esophageal disease, but it does seem to have rising prevalence. It's a chronic immune-mediated disorder that's manifested by symptoms related to esophageal dysfunction, as well as an eosinophil predominant inflammatory response in the esophageal mucosa. It seems to be triggered by interluminal allergen exposure, with food antigens being the largest culprit as opposed to aeroallergens. And it has a very heterogeneous clinical presentation that varies based on age and genetic factors and environmental exposures. Diagnosis does require an EGD with biopsies, and fortunately most patients respond well to therapy, either therapy with topical steroids or an elimination diet. And I would argue that timely referral to pediatric GI is important because these patients can go on to develop fibrostenotic disease if they're not picked up and treated soon enough. So I'm going to end there, and I just want to take a moment to make sure all of you have heard about this new clinic that Dr. Garcia-Lorette and I have developed over the last 6 months or so. By name, it's technically the UCLA Pediatric Celiac Disease and Eosinophilic Esophagitis Clinic, and part of that is so that families can find it online when they're doing internet searches. But behind the scenes, we actually refer to this clinic as our GAIN clinic. It's a collaborative gastroenterology, allergy, immunology, and nutrition clinic. And the reason is that we're really hoping to capture and treat all patients with allergic and immune-mediated GI disorders. So it doesn't have to be a patient with celiac disease or EoE who's referred. We're happy to see patients who may have gluten sensitivity, other kinds of food allergies and food sensitivities, the famous FPIs and some of our little ones, as well as the oftentimes very difficult to treat cow's milk protein intolerance in babies. And we're also seeing a number of patients that have complications associated with primary and secondary immunodeficiency states. So I just want to take a moment to acknowledge Dr. Garcia-Loret and Diana Saicali, who have been very helpful in establishing this clinic. And thank you, everyone.